and if there are any issues in between, we'll try to address those there and then only.
Okay, sir. Good morning, sir. I'm Dr. Darshan Patel from Dullabji Hospital, Jaipur. Uh, Today, I'm presenting a case of 60-year female resident of Alwar, occupation farmer by occupation. She came with chief complaints of yellowish discoloration of sclera since 7 days. Patient was apparently well before 3 months. Then she developed right upper quadrant pain and yellowish discoloration of eyes. Pain was localized in the right upper abdomen, continuous dull aching, sudden in onset, no radiation to back, aggravated by food intake and relieved by IV analgesic. She noticed yellowish discoloration of sclera, which was non-progressive, associated with high color urine, not associated with clay-colored stool or pruritus, and it is also not associated with any prodromal symptoms. There is no history of fever, vomiting, no history of any lump in right upper abdomen, no history of hematemesis or melena, no history of loss of appetite or loss of weight, no history of abdominal distension. Patient was evaluated with some radiological investigation and she underwent some endoscopic stenting procedure, following which jaundice got relieved and the patient advised for conservative management for 4 weeks. She underwent open cholecystectomy on 2nd of January 2024. The operative details are operative time was around 2.5 to 3 hours. Drain was placed and specimen was removed in the bits and pieces and was not sent for biopsy. There was no need for any blood transfusion. Oral liquids allowed on post-operative day 1. She developed green colored fluid in the drain tube around 500 ml on the post-operative day 1. Patient was managed conservatively and discharged on the post-operative day 6 with drain in situ. She underwent MRI abdomen after 20 days, following which an endoscopic procedure was attempted but could not be completed as per history. Drain output declined gradually over the next 1.5 months and drain was removed 1 month back on the OPD basis. She never developed jaundice, fever, abdominal distension or vomiting during this period. Now she came with complaints of yellowish discoloration of sclera associated with high colored urine, clay colored stool and pruritus since 6 days. It is not associated with abdominal pain and distension, fever, vomiting, loss of weight and appetite. There is no significant past history, no history of similar complaints in the past, no history of any other surgeries, there is no history of any comorbidities. Personal history, patient is she consumes vegetarian diet, non-alcoholic, non-smoker, normal bowel and bladder habits with normal sleep pattern. Family history is not significant. A 60-year-old female came with complaints of pain in abdomen and non-progressive jaundice, underwent some endoscopic stenting followed by open cholecystectomy, which led to a controlled external biliary fistula which closed spontaneously. Now she presented with yellowish discoloration of sclera associated with clay color stool and pruritus with no history of loss of weight and appetite.
Why do you say non-progressive jaundice based on history?
Yes, sir.
How did you come to this conclusion that it was non-progressive?
She had sudden onset of jaundice, sir, which was relieved by the endoscopic stenting. And in between this period, sir, she never developed jaundice.
No, you were written non-progressive jaundice. So what I'm trying to ask is, like in history, what are the features which led you to conclude that she had non-progressive jaundice? The level of jaundice was constant.
When she came with when she had first episode of pain in abdomen and jaundice, sir, it was around, sir, 5 to 6 days she developed pain and jaundice, sir. After that, sir, she underwent radiological investigation and stenting.
So she did not tell you what investigation she underwent?
Sir, she tells us US ultrasonography.
Okay, because you have given the operative details in actually very fine things are also written, but you are not even telling the name of the investigation. So like.
So actually, the history was given by her relatives.
And operative details, they have shared the discharge summary. So you.
No, sir. No, sir. They didn't give any discharge summary.
You written that it was removed in bits and pieces and all these things. So.
The specimen was shown to the relatives. It was.
Wait, just show me the operative details.
Yes, sir.
So you written operative time, drain obviously patient can tell you whether the pain was there or not. So,
Yes, sir.
like all these details were there in the discharge card. So there you have taken.
No, sir. Actually, they didn't give any discharge summary or any discharge card, sir. It was all told by her relatives, sir.
Okay. So did you have access to the pre-operative ultrasonography?
Yes, sir.
You had.
Yes, sir. I will share it
Okay,
in
fine,
later,
fine.
sir.
So okay, from the history, what do you think is happening? What are your provisional
Uh,
differentials?
Sir, my provisional differential diagnosis, sir, post cholecystectomy bile duct injury with controlled external biliary fistula, which developed into benign biliary stricture.
Okay, okay. Any other thing which you can think or which could have happened?
Sir, it can be, sir,
When was this
retained.
surgery? When was this surgery done?
Surgery was done in the first 2nd of January, sir,
January.
2024.
Around
Yes.
6 weeks after surgery, 6 to 7 weeks, right?
Yes, sir. After the
After
episode,
surgery.
yes, sir.
So now the history of jaundice is for last 6 to 7 days only.
Yes, sir. In between that period, sir, after the patient got discharged and controlled biliary fistula was there, sir,
Okay, the day
then
was
it
there and
spontaneously closed.
okay, okay, okay.
And then, sir, patient was apparently well around 1 month. And after then, she developed jaundice and pruritus.
Apart from bile duct injury, anything else can happen which can present in a
Sir,
similar way.
it can be, sir, retained CBD stone, but patient was preoperatively stented,
In your
so
differential, you have nothing but biliary stricture following bile duct injury.
sir, it can be, sir, retained CBD stones, but
Okay,
from the history, she was preoperatively stented, so possibility is less of retained
okay,
CBD
okay.
stone.
Fine, fine. Anything else you can think of? So if I say it was a missed carcinoma gallbladder, is it possible?
It can be, sir, but
Yeah, based on history, I'm not.
base,
You have access to the previous record also, but like
yes,
based on history only.
sir, yes, the specimen was not sent for the biopsy first, and
Yes.
the age group also correlate with the
Patient is in North India, age group is there,
and
bits
from
and
the North India,
pieces,
sir. But
removed in
sir,
bits and pieces,
yes, sir.
biopsy is not
Uh,
available.
yes, sir. But sir, from the history and the clinical presentation, sir,
Mhm.
the carcinoma gallbladder is less likely, sir, because she has not progressive jaundice, and the first instance when the jaundice was present, it was painful jaundice.
So carcinoma gallbladder, you are trying to say is painless. It presents with painless jaundice. What is the typical history of a patient with carcinoma gallbladder? Obviously, they can be varied presentations, but how do they present?
Sir, a lump in abdomen, sir, right upper.
One patient, but like uh, suppose a patient is having gallstones, they can have repeated episodes of biliary pain, and suppose when the carcinoma develops, okay, when the carcinoma
Yes, sir.
develops, usually the pain becomes constant. That is a change in the character of pain, which is seen typically with carcinoma gallbladder patients. But yeah, it's not that it is essential the history to be like this. So it's not
Yes, sir.
painless, right? Because 90% of carcinoma gallbladders they will have associated stones. So they will they're likely to have some history of pain which may be related to colic or maybe for use of carcinoma, anything, you know.
Yes,
So
sir.
painless jaundice is not characteristic of carcinoma gallbladder.
Yes, sir. And so she also didn't have any complaint of loss of weight and appetite.
Okay. Okay, fine. If it is so, these things are this good. If they are present, probably there are additional corroborative findings to suggest that there can be a malignancy. But I don't think absence of
Yes,
these things can rule out a malignancy.
yes, sir.
So somebody is asking why green color fluid in the drain. Uh, she's asking that it should have been yellow if it was a biliary fistula. What are your comments on this?
So, like, actually, the hepatic bile is somewhat yellowish colored, sir. The
Okay.
bile which drained from the gallbladder or from the uh, CBD, sir, it is somewhat greenish and viscid. The fresh bile that comes from the
But
main biliary duct or
the bile which is coming from CBD also is fresh only. Within 2 centimeters, how come it becomes so green and not so fresh? So, like you're telling that if it is from hepatic ducts, it will be very yellow, and if it
yes,
is
sir,
from the CBD 2 centimeters below that, it will be green.
from the gallbladder and
Gallbladder is already out, na?
yes,
Like in our case, gallbladder is out already. So,
yes, sir. It was already told by the sir, patient relative, sir, actually.
all right, because
Yes,
in history, the person was asked the question. In history, patient may tell yellowish green. So, like these colors and these specific words which we use may be used by the clinicians based upon their experience. But I think for patients, it can be yellowish green or yellow greenish. So I think all the things can be there. But if it is very very green, dark green, maybe there is associated duodenal injury also. No? It is
yes,
possible.
sir. It can be duodenal injury.
All right, all right. So provisional diagnosis, bile duct injury. Okay, go ahead. Yeah.
Yes.
So
So
it's fine
general
because the history is very typical, but you should always keep in mind the other possibilities which are there. Because in exams, right now you know the
yes, sir.
diagnosis, you know the workup, you already know the patient, okay? But in
Yes, sir.
exams, you may not be knowing all these things, and even if you know, it should not be very apparent during your discussion that you know everything. Okay,
Yes, sir.
okay, fine, go ahead.
So general physical examination, patient is conscious, cooperative and well-oriented, average build and moderately nourished with BMI of 24.8, ECOG score 1. Icterus is present. There is no pallor, cyanosis, clubbing, lymphadenopathy or pedal edema. Pulse is 78 per minute, BP is 134 by 84 millimeter of mercury, respiratory rate is 18 per minute and afebrile. There is no signs of liver failure. On abdominal examination, on inspection, abdomen is flat, umbilicus is central and inverted. There is right subcostal scar with stoma bag in situ at the previous drain site. No visible peristalsis or pulsation on sinuses or engorged veins. Hernial sites, no visible cup impulse. External genitalia normal. Renal angles normal. On palpation, abdomen is normal temperature and non-tender.
What are the contents of the stomach bag, which was in situ at the previous drain site?
Sir, actually, she was telling that it was not draining content since last 6 to 7 days. Sir.
Okay. So
Yes, sir. On palpation, abdomen is normal temperature, non-tender, scar site non-tender, no discharge from the scar, liver palpable just below the right subcostal margin, and spleen is not palpable, hernial sites normal. On percussion, liver span is 12 centimeter in mid-clavicular line. Flank is tympanic, normal bowel sounds heard, and on digital rectal examination, sphincter tone is normal, no palpable mass, or gloved finger stain with clay color stool. Other systemic examination within normal limits. Shall I
come back,
proceed
come
for
back, come back. Previous slide. Yeah. So, can you, tell me one point from on this slide which is important and which is giving you some information regarding the disease process which is going on.
sir, on digital rectal examinations, glove finger stained with the clay color stool.
So,
There is no biliary ductal continuity is there, sir.
there is no
If the clay color stool is suggestive of the complete cutoff or the bile is not draining into the
Okay,
duodenum, sir. There no continuity is there.
fine, fine. Okay, okay, good. Go ahead. So, liver span 12 centimeter. What does it signify?
Sir, it is within the normal limit, sir. There is no hepatomegaly.
Previous slide. So, this on palpation you've written normal temperature and non-tender. This is what temperature of
Uh,
abdomen is normal.
yes, sir.
Okay. So
And
in what instances you will expect the temperature to be raised?
if there is any localized collection or abscess is there, sir, there might be slight,
In intra-abdominal abscess.
no, sir, in subcutaneous plane or in,
So maybe at scar site only, no?
yes, sir.
Okay, fine.
Shall I proceed for
Yeah, yeah.
investigation? The complete hemogram shows hemoglobin is 10.6.
After examination, do you think examination also has contributed to your diagnosis?
Sir, after examinations, few points like there is on inspection, subcostal scar is present,
Hmm.
and the stoma bag in situ, which is not draining anything. So the fistula has been closed, and it is now being converted into the benign biliary stricture.
Okay.
And on digital rectal examination, the glove finger stained with clay color stool is also suggestive of there is complete cutoff of the uh,
So can you think of a situation where external biliary fistula has closed, but still there is staining of fingers with normal colored stools? So what does it signify?
so there might be any internal visualization. So
Yeah, yeah, yeah.
the
So,
continuity is maintained with in spite of
so
external
they can be either a
biliary
partial continuity, okay, through the normal,
normal bile
yes,
from the
or they can be an internal, abnormal internal fistula which is formed and they just restore the flow of the bile into the intestines, okay?
yes sir.
Okay. Yeah. Go ahead. Yeah.
Also hemoglobin is 10.6. Total WBC count is 12 points, around 12,000. Platelets 2,94,000. Renal function test shows creatinine is within normal limits. Sodium 135. Potassium is 3.7 and prothrombin time is 13.3 and INR is 0.95. On liver function test, SGOT-BT are raised around 277 and 273. Total bilirubin is 7.6, direct is 6.1, albumin is 4.2, globulin is 4.1, and alkaline phosphatase is GGT are also raised.
Okay.
So,
So, how do you interpret these findings? Is there anything wrong with the findings, or tests as
uh,
normal or as expected?
the liver function test is grossly deranged. It shows raised bilirubin with direct component is specifically raised. So,
It is
and
fine. Okay. So when do you
and
call it uh, obstructive jaundice?
yes, sir.
When do you call it? Based upon the bilirubin and direct component. So you are stressing that direct bilirubin is 6 and the total is 7.6.
So, sir, so out of direct is raised and indirect bilirubin components are it
That's fine.
is
Suppose had it been 2, direct bilirubin 2. So how would it have made any difference in your interpretation? So is there any cutoff for the percentage of direct bilirubin which suggests that this is obstructive jaundice or cutoff for cholestatic jaundice? This is obviously very, very high, but what I'm telling is suppose total bilirubin is 7 and direct is 3. So,
yes, sir.
so is it obstructive or not? I hope you're getting my question. So, is there
Yes,
any
sir.
cutoff of the percentage of direct bilirubin with respect to total bilirubin beyond which we say that this is probably obstructive jaundice, or is there a cutoff for direct bilirubin percentage which says that this is a cholestatic jaundice? You know it or not? You can say yes or no.
I don't know, sir.
Okay. So beyond 15%, if the direct component is there, we call it cholestatic jaundice.
Yes,
Okay.
sir.
Usually in patients with obstruction, biliary obstruction, the direct component will be 50% or more. Okay. But 15% is the cutoff beyond which we say it's direct hyperbilirubin. Okay.
Yes, sir.
So SGOT, SGPT,
It is raised, sir. As your OTBT is also raised.
what does it tell you?
Yes, there is some
Patients having
cholesterol.
hepatitis, viral hepatitis.
No, sir, it is not that grossly deranged, sir. It is
Okay. So what is
just
that cause
about.
beyond which you say that it is viral hepatitis? Again, cutoff will be there, right?
Yes, sir.
When will you say? It is very important to interpret the LFTs, right?
Yes, sir.
From these LFTs, what do you make out?
From these LFTs, there is bilirubin and bilirubin is
Which
raised
type
with.
fever? Fever spikes are there?
Sorry, sir.
Fever spikes are there?
No, sir. She had never complained of any fever spikes
So
or any other prodromal
TLC
symptoms.
is 12,000, which is slightly increased from the normal upper range.
Yes, sir. But
AST and ALT both are raised. ALP is raised,
yes,
ALT
sir.
is raised. So, what do you think? Why would
It,
AST and ALT will be increased in these patients? So, typically,
due
in
to
which
some
cases you see AST and ALT increase?
cholestasis is there.
It will lead to increase in AST and LT. Again, as I told, you should know the cutoff value. Like if it is more than 3-fold, then we should suspect something else. If it is more than 10-fold, then we should suspect something else. Okay. If it is
Yes, sir.
within 3 times, it can be raised in cholestatic jaundice also. But I would say with the TLC of 12,000 with AST-LT raised like this, I will suspect a subclinical cholangitis. Did you think of it?
She's a patient. She didn't give any complaint of fever with chills or any abdominal pains,
What
sir.
is
So,
subclinical cholangitis?
sir, it can be. Sir.
Yeah, it can be. Not because I'm saying, but what do you interpret by this word?
Yes, sir. If the TLCs are raised, sir, SGOT-BTs are marginally raised.
So in cholangitis also this will be raised. Okay, again, not maybe 5-fold, but like up to 3-fold rise can be there. So with obvious obstruction in the biliary tree, with ALP raised, bilirubin raised, TLC also is raised. So I think you should think on the lines of subclinical cholangitis also. Okay. Okay, fine. Go ahead. Next slide.
So this is USG done before the cholecystectomy, sir.
Okay.
It shows the liver is mildly enlarged in size with margin are regular and smooth with normal liver parenchyma with echo texture with proximal IHBRD or proximal IHBR are mildly prominent. The gallbladder appears contracted and gallbladder wall appears inhomogeneously thickened. The echogenic foci are seen in relation to the gallbladder fossa. The proximal CVD is mildly dilated with maximal dilatation is 7.6 mm.
Okay. So what do you make of it?
So from this USG report, sir, there is proximal IHBID is there. So there might be, sir, possibility of, sir, any.
What is proximal IHBRD?
Sorry, sir.
What is proximal IHBRD?
The secondary and primary biliary radicals.
So proximal is from where does the interbody radical start?
From the
From liver hilum?
No, sir, from the level of first order biliary radicals, sir, from the right and left hepatic duct.
From there, IHBR starts. So intrahepatic biliary radicals, which part is proximal and which is distal? So I think rather than writing proximal and distal, people usually write peripheral and central. Okay. So like if somebody wants to say that at hilum, the CHD is prominent near the hilum and right and left are also prominent, but there is no peripheral IHBR dilatation. So this is how people write. I know this report is slightly confusing because biliary radical they start in the periphery. So there cannot be a case where the peripheral parts are dilated and central parts are not dilated. Until unless we have something else like biliary ectasia or some biliary cystadenoma kind of a thing or a peripheral intrahepatic cholangiocarcinoma. So probably this person wants to say that the central ISPR are prominent and peripheral are not dilated, right?
Yes.
Okay.
And the gallbladder is also appear contracted.
Yes.
So there might be possibility of chronic cholecystitis.
Yes. But
and
read the next line. Probably it will give you more insight.
With gallbladder wall appears inhomogeneously thickened.
Yeah. Okay. What do you make of it? What does it signify? What is inhomogeneously thickened? What does it mean?
Asymmetrical thickening is there.
Okay. And what does it suggest?
Possibility of carcinoma of gallbladder.
And we should definitely think that. Because so how do you differentiate between thickening of a benign disease in the gallbladder versus thickening because of a malignancy? What are the various differentiating features?
Sir, in benign disease, there is symmetrical GB wall thickening is there.
Okay. So throughout there will be thickening, which is constant, similar thickening. Okay?
With some
covering almost all of the gallbladder.
Yes, sir. With some.
But in GB carcinoma,
asymmetrical wall thickening with some polyp or mass can be seen.
Polyp can be there, but right now we are talking about thickening only. So obviously, if there is a mass, that is we have to think on the lines of carcinoma, but we are right now talking about thickening of the wall. So how is the thickening in carcinoma different from thickening in chronic cholecystitis?
It is not symmetrically thickened, sir. At some
Focal thickening. Focal
focal
thickening,
thickening.
asymmetric. Yeah, absolutely. Inhomogeneous, like the person has written.
Yes.
Okay. So it should definitely force you to think that there is a possibility of malignancy. Okay. Mm. So dilatation of CBD.
Yes, sir. Proximal CBD is mildly dilated.
So what are
So
the reasons?
can be the possibility of any neck stone which is compressing the GB neck stone compressing the CBD.
Again, the thing is, this is CBD dilatation. This is common hepatic dilatation. It's very important to differentiate, right? GB neck stone compressing leading to Mirzi kind of picture will lead to CHD dilatation. Whether this person wants to say that it is CBD or CHD, we are not clear. Okay. What is the other possibility apart from GP neck stone compressing the CHD and causing Mirzi like picture? What is the other possibility?
The GB mass probably in the neck which is infiltrating the
Okay. What else?
CHD.
What else? No other possibility. Can it be CBD stone?
So
Stone which
CBD
is
stone, yes, possibility of CBD stone.
considering the history which you have given, that person has undergone some endoscopy and then the jaundice is got relieved.
Yes, sir.
And that should be the first possibility, right?
Yes, sir. CBD stone.
Okay. Okay. Fine. So, so do you have LFTs prior to this ultrasound or at the time of this ultrasound before surgery?
No, sir. No, sir. They
Did
have
the
just
patient give
US
history
syrup.
of jaundice before surgery also? No? Patient gave history of jaundice, right?
Yes, sir.
Okay. Okay. Fine. Go ahead.
So this is the ERCP
So
report which is done on.
based on history, can you differentiate between pre-hepatic, hepatic, and post-hepatic causes of jaundice?
At the first instant when the first episode of pain was there.
No, no. Like in any given patient who has come to you with jaundice, can you
Yes, sir.
differentiate whether the cause is pre-hepatic, hepatic, or post-hepatic based upon history?
In the hepatic jaundice, there might be any
I'll again
prodromal symptom
no prodromal. Okay, okay.
that like fever, and loss of appetite, loss of weight.
So that is for viral hepatitis.
Yes, sir.
But if
And
there are other
with
causes, hepatic jaundice,
so pre-hepatic jaundice, a patient give
right? Okay,
complaints of
I'll further simplify the question. So, based upon history of
yes,
discoloration of eyes, yellow colored urine, high colored urine, and clay colored stools, can you differentiate between pre-hepatic, hepatic, and post-hepatic causes of jaundice?
sir. In a pre-hepatic jaundice, sir, there is uh, yellow present of clay color stool can be there, sir, in
In
pre-hepatic
pre-hepatic,
jaundice.
how come?
Sorry, sir. Sorry, in post-hepatic, sorry. In post-hepatic jaundice.
Okay. What about the other two?
In hepatic jaundice, sir,
So, in pre-hepatic jaundice, usually the patient will have only jaundice, urine will be normal,
jaundice,
stool will be normal. In hepatic jaundice,
the,
there will be
yellowish,
jaundice
this,
and urine color will be raised. Okay, but clay color stool will not be
but
there. In post-hepatic, all three will be there. Okay. Chalo. Next.
yes, this is the ARCP report, sir,
Mhm.
on 16th of November, sir, pre-operative ARCP.
Okay.
It is the papilla is a normal periampular diarticulum present. Its selective CBD cannulation was done, and cholangiogram revealed dilated IHBR with mild compression at the cystic duct level with no filling defect in CBD. The biliary sphincterotomy they have done and put a 7 French depleted plastic stent in the right hepatic duct. After that, the free flow of bile is seen.
What is
They have
DPT?
concluded.
Diphtheria, pertussis, and tetanus. You see, these are something which we read day in day out. Like you must be reading these reports day in day out. But if you see the picture, last picture,
Yes, sir.
probably it might give you a hint.
Dual prong,
Double pigtail.
double fit.
Both our ends are coiled.
Yes,
Okay. So, I
yes,
mean, these things are. It's not just testing your knowledge, but because you see all these reports day in day out, we should be familiar with the terms which people are using because they assume that everybody who's reading the report, that person is also familiar. Okay, and being a surgical gastroenterologist, you should definitely be familiar with the terms. Okay,
They have
fine.
concluded that can be query Milzi syndrome with cholelithiasis.
Okay, so what is Mersey syndrome?
So this is the it is a cholecystocoli there is a cholecystocolidocal fistula is there. Sir.
Cholecystocolydocal fistula. So Mersey syndrome means there should be a fistula, right?
No, it
Have
can be, sir.
part of any classification of Mersey syndrome given by
Yes, sir.
various people?
Sir, it can be just compression like in type 1 Mirzi. The
Which classification you were talking
distinct
about?
duct,
This is which classification? Just like bile duct injury, you know who was given bile duct injury classification? Which classification
yes,
which
sir.
you use in your
This
practice?
Strasbourg classification, sir, we use.
Okay, just like that also, somebody might have given the classification about this also, no, Mersey syndrome. How do you classify the various degrees of visualization or compression?
Yes, sir. The type 1, 2, 3, 4 are
That's
there.
fine. But what is this classification name? Some people have given simplistic classification of either compression or fistulization. And some people have even classified the fistulas into various degrees. So you should read, no? One classification is by
Yes, sir.
Bakhtiari, which is simple fistula versus compression. One is Sentis, and CSE.
Yes,
So
sir.
you should read the classifications. Uh, if you do not know the detail, at least grossly you should be remembering the four types. Okay.
Yes, sir. Type.
Okay. Go ahead.
So this is the pre-operative ERCP, just the before the cholecystectomy was done.
RCP.
Sorry, sir, MRCP.
Okay.
Sir,
This is
it is
before
before the open cholecystectomy was done.
previous surgery. Okay, fine, fine.
Yes, sir.
Right.
Before the index surgery.
Okay.
Sir, this 3D reconstructed image of MRCP shows the bilobar IHBID is there,
Yeah.
sir.
Yeah, yeah.
With there is complete cutoff just below the hilum, sir.
Okay. Just below the hilum. This is where is the gallbladder? This is not just below the hilum. Hilum is quite up. Hilum is
Yes, sir.
up there.
Yes, sir.
Maybe mid CBD we can see. Probably where the sixth
Yes, sir.
gallbladder struct is joining.
Gallbladder is joining to.
Yeah. It's low only. It's not at the hilum definitely. Okay.
Yes.
So what does it suggest?
So there might be compression, sir. Probably due to the compression. Uh,
Why not? Why not some filling defect in the bile duct?
Actually,
Gaurav sir,
G.
hello. Am I audible?
Yeah, audible.
Hello. Am I audible?
Yes, you're clearly audible. Please.
Yeah, Gaurav sir, we have to wind up in another 5 minutes because
Yeah,
we
I
are
know. I
reaching
also
by
have.
time. Sir. Yeah.
Sure. I'm just
See.
keeping an eye on the watch.
Yeah.
Yeah, sure. Fine. So,
sorry, because in ERCP there is an filling defect or
okay. Fine. So, next, what do you want to do?
sir, the patient came with his complaint of the yellowish discoloration of sclera and K color stools. Sir, probably sir the fistula has been closed and she
That's fine.
has developed.
What do you want to do?
Sir, I would like to sir review all the previous medical records. Sir.
You have reviewed already, no? What do you want to do?
Yes, sir.
You have shown the
Sir,
MRCP and ultrasonography before the surgery. So, what do you want
yes,
to
sir. This ultrasound is after the surgery.
do? Okay.
After the surgery has been done. After the 26 post-operative days.
Okay.
It shows that there is no evidence of any abdominal intrahepatic and focal intraparenchymal lesion with mild dilatation of intra and extrahepatic biliary radicals.
Okay.
CBD is also dilated in diameter around measuring 19 mm with phi calculi is noted in the lower CBD measuring 16 mm.
Okay.
And the CBD stent is noted in situ.
So, what next?
Sir, there is also she's also underwent MRCP and ERCP, sir, post-operatively.
What does it say?
So the post-operative ERCP report is not available, sir, but the descriptive finding was there, which suggests your wire is not going into the upper CBD. We query complete transaction of the CBD.
Okay. So this confirms the only differential which you had kept. Okay.
Yes, sir. And this is the post-operative ERCP, sir.
Okay. MRCP post-operative. Fine. So what will you do?
MRCP.
How will you treat?
First, sir, I would like to know the
one line answer. If everything is perfect,
develop the benign.
Everything is perfect and patient is all right. Everything you've taken consent and everything.
Sir,
what are you going to offer to the patient?
She has developed the benign biliary stricture. So
what are you going to offer? Don't beat on the bush.
So I would like to go for the operative intervention.
What? Yeah.
I would like to do.
Tell the
I would
surgery.
like to do hepaticojejunostomy, sir.
Hepaticogenosmy with
Okay.
what? Loop of jejunum.
The Roux-en-Y,
You should.
Roux-en-Y hepaticojejunostomy.
If I'm asking what surgery you want to offer, you should tell the name of surgery. Okay. Rest of things, okay.
Yes,
Probably
sir.
could have discussed if we had started in time. Okay. But
Yes,
I think it's 9:58 now. We'll break for the day. Thank you very much.
okay. Thank you.
Thank you, Gaurav sir, for moderating today's session. So we will ask Dr. Darshan Patel later on. So to complete his entire this case,
Okay.
Dr. Darshan, am I audible to you?
Yes, sir. Yes, sir.
We will just keep this case with you. So in next further class, we will complete this case. Okay, you are
Okay.
comfortable with it? So
Yes,
I will ask Anand to coordinate with you to make a session with you. Okay.
Sure.
So
Sure.
Gaurav,
Thank you.
yes, sir.
thank you very much. So we are closing our session today. Thank you very much.
Thanks a lot. Thanks a lot for having me. Thank you.